All right, good evening. Hello and welcome, everybody. Thank you for joining us for our July All Hands call. We are joined today by two very special guests. Dr. Shankar Prinja, the Executive Director of the National Health Authority, is here to walk us through his latest consultation paper for the National Health Authority, which is titled From Volume-Based Care to Value-Based Care, Ensuring Better Health Outcomes and Quality Healthcare under Pradhan Mantri Jan Arogya Yojana. We also have Dr. Chintan Maru, CEO of Leapfrog to Value, an organization which partners with institutions to build human-centered health systems in India, South Africa, Ghana, Kenya, and beyond. Dr. Maru will be moderating the Q&A session which will follow. Before we begin, a note for our attendees: if you have questions, please do either of the following at the end of Dr. Prinja's presentation. Firstly, you can type your questions in the Q&A box. There is a chat box at the bottom of your screens, or alternatively, you can raise your hand. If you do type your questions out in the chat box, there is a greater likelihood we will be able to accommodate your query. In case we run out of time, you can also email us your queries at allhands@swasthapp.org. There is an email ID given at the bottom of your screen again. Your question shall be sent to the panelists following the call, and we will get back to you with their responses. Before we begin with the call, an introduction to our eminent speakers. Dr. Prinja currently serves as the Executive Director for NHA. He is also a Professor of Health Economics at the PJMR School of Public Health, Chandigarh. After specializing in community medicine and public health, he trained in health economics at the London School of Hygiene and Tropical Medicine and at LSE and Political Science. He has authored over 200 publications across the areas of health economics, cost effectiveness analysis, equity analysis, and healthcare finance. Our moderator for the day, Dr. Chintan Maru, is a medical doctor and public health expert who currently leads the Leapfrog to Value initiative. He is a graduate of Johns Hopkins School of Medicine and majored in political science at Duke University. He was also a public policy and international affairs fellow at Princeton University, as well as a US Fulbright scholar to Jamaica. In his previous role at McKinsey & Company's health systems practice, he led value-based care reforms for payers, providers, and governments in the US, as well as advised on public sector delivery transformations in sub-Saharan Africa. With that, I hand over the call. Very excited to have the both of you with us here. Dr. Prinja, all yours. You may share your screen.
Sorry, can you confirm if you can see the slides on full view?
Yes, your slides are visible.
Thank you so much. And thank you to the organizers for having invited us to share these thoughts. And this is basically the presentation that I'll run you through is basically an in-depth insight into the consultation paper that we very recently floated on the NHA website, that talks about the broad intent of the National Health Authority to transform the scheme from a more of a volume-based to a value-based healthcare. And basically, it has two sections, this consultation paper. The section 1 talks about the broader concepts of value-based care that exist, and the broader connotations of value-based care that we're trying to integrate within the scheme, which is the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. And while I say that we've tried writing up this first section or the first chapter, it's by no means is it a very comprehensive overview of all that possibly could get within the embed of what we call as value-based care. So there could be a number of other things that could be there, but we try and define at least some of those things that we're trying to integrate within the overall connotation. So basically, the intent is that we want to drive the entire system towards value-based care. And one of the things that we want to do that through is by the creation of the different incentive structures. So originally we used to, in most of the traditional methods of provider payments, we generally had the payments that were linked to the volume of services being delivered. So whether these are fee for service or whether these are case-based payments, these are all areas where we relate the amount of payment that is delivered to a given provider to the amount of services or the volume of services that are delivered. However, there is not much emphasis on the overall patient outcomes and the quality of care, etc., which is aimed at being assessed as part of the initiatives towards value-based incentive systems, where the amount of payment that a provider receives is largely related to the outcomes of the patients who are being treated and the quality of care that is being delivered. And it is not to say that there are no current initiatives to promote quality within the overall ecosystem of PMJY. There are a number of initiatives, and also there is enough evidence to suggest that there is a need to work on this area. So in one of the recent Lancet commissions that was published in 2018, it basically tried showing that the proportion of mortality that is amenable with appropriate healthcare, if we try and break it down within the low and middle income countries, 40% of this amenable mortality could be attributed to lack of access, whereas the remaining 60% is on account of poor quality healthcare. And as a result, there are different initiatives within PMJY where we're trying to improve the quality of care that is being delivered. And these initiatives work on both financial and non-financial nudges. So for example, if I move from left to right, we're trying to set up at the state level, at each of the state implementing agency, which is called as an SHA, a quality cell that specifically focuses on the quality of care, etc. And in doing so, there are certain supervisory checklists that have also been prepared, terms of reference of these quality cells that have also been prepared, and there is a general capacity building of these quality cells also that is undergoing in order to make sure that they are able to work with the empaneled hospitals and help them improve the quality of care. Besides that, there is a focus on trying to improve the inputs and infrastructure at the hospital by creating some kind of certification standards or accreditation standards. So within PMJY, we have quality certification where we accord hospitals at the level of bronze category, silver category, or gold category. And the silver and the gold are commensurate with the NABH entry and the full accreditation levels. And the overall bronze category is something that certification has been developed, criteria have been developed through a partnership between the NHA and the Quality Council of India. Besides this, we also have for public hospitals, we have the NQAS standards, which is again a standard that has been set specifically for the public hospitals. And we equate the NQAS certified public hospitals as equivalent to a gold certified hospital or a NABH full accredited hospital. We also have other forms in which we recognize hospitals that perform better. So for example, recognizing the hospitals on important days which perform better in terms of quality, etc. And also in terms of incorporating incorporating quality as an important aspect in all our IEC and communication during different celebration of international days, etc. More recently, we have also been trying to set up for super specialty care, the NABH Center of Excellence. And as I mentioned, that these quality certifications are actually linked with certain financial incentives. So if you have a bronze or a silver or a gold accreditation certification, then you are entitled to 5, 10, and 15% incentive over and above the price that is actually set for a particular package or a procedure. So whatever is the price, you get a 5, 10, or 15% higher price for each of the services that you are delivering. And moving forward, we are trying to say that we want to move towards value-based care, where the outcomes that we want to achieve is that we want to achieve improvement in quality of care that helps ultimately improve the outcomes for the patients. Hospitals and providers ultimately become partners in the overall management, whereby they help the patients to improve their health. The entire processes of delivering of healthcare are standardized. So this involves creation of standard treatment guidelines. This involves creation of some kind of certification standards that represent the appropriate level of input process, etc. And eventually all of this aims at improving better efficiencies for the payer. So which means we deliver care that ultimately is cost effective, that that represents a value for money that is being spent. And when we try and look at it from different lenses and different perspectives, there could be different connotation of value in the overall value-based care concept. So for example, in case of individuals, for a personal patient, the value-based care eventually boils down to the best possible level of treatment that is delivered, which is evidence-based and which is delivered in a manner that is responsive to the needs of that particular patient. On a payer side, there is an intent towards maximizing the efficiency, which means that you're able to generate the best possible level of outcomes with the available resources. You also want to ensure that there is some distributive justice. That means the allocation of resources is equitable across all patient groups, across different geographies, across any other patient or population subgroups as well. And ultimately, this all represents in terms of creation of a value at the societal level, where a healthier population is able to contribute better in terms of social participation. And if we look at each of these different connotations of value-based care, we can see that there are different aspects that are being integrated within PMJY in order to enhance the value of the overall scheme. So if we move clockwise, starting from here, we are trying to set up different processes whereby there is an integrated care that is delivered. And this happens through a continuum of care that is being established between the different two pillars of Ayushman Bharat, so that, which is the Health and Wellness Center on one side and the PMJY on the other side, so that there is some integration in terms of the primary, secondary, and tertiary care. The health benefit package has also been revised recently with creation of more follow-up packages, because we recognize that in certain specialties, there are very costly and complicated procedures that are done, where the care ideally does not stop at the end of hospitalization, and following the discharge also the patient requires care. And unless that is done, it leads to a failure or a complication of the procedure, which may need a re-hospitalization or a re-procedure that needs to perform. So in order to make the scheme more efficient, there are these follow-up packages that have been introduced for certain packages that are performed in either cardiology, cardiothoracic surgery, urology, etc. And then there are certain daycare packages also that have been added, specifically in the context of specialties like mental health, where you do not necessarily encourage a hospitalization for each episode of care, but you require a detailed kind of assessment, follow-up, a kind of a psychometric evaluation of the patient, and treatment that involves both pharmacological and non-pharmacological approaches. So there are, as I mentioned, there are different ways in which the integration of care delivery is being attempted. We're trying to also expand on the geographic reach of the providers, whereby there is an attempt to have a differential pricing, which tries to at least give some degree of consideration of the differences in costing structures that operate at hospitals located in different cities, and also provide with a social policy objective. There is also an additional incentive that exists for hospitals that are located in hard to reach areas, vulnerable districts, which are identified as aspirational districts. So in close to about 116 aspirational districts in India, we have about nearly 10% additional incentive that is given on price of each package. And this is to recognize the fact that there is a higher cost of care that is involved in delivering care in these areas and hospitals, and we need to incentivize hospitals to go and doctors to go and work in these areas. There is an attempt towards creation of strong IT platforms. We know that PMJY's scheme runs in a paperless fashion on the backbone of a strong transaction management system. And moving forward, there is also an attempt to taking this to a new level with the coming in of the Ayushman Bharat digital mission, which creates an ecosystem of information exchange across different stakeholders, whether these are providers or patients or manufacturers or even the intermediaries, like, for example, the labs and the pharmacies. There is also a significant effort being made towards instituting performance-based payment systems. These examples of these involve DRG-based payments, for which a pilot is currently ongoing in 5 states. And in the next part of the presentation, I'm going to introduce the concept of value-based incentives that we have proposed as part of this consultation paper. There is also a very concerted effort towards systematic process of measurement of costs and outcomes. And these are basically linked to creation of a new unit within the NHA, which is the Health Financing and Technology Assessment Unit. The aim of this unit is to actually set up processes whereby each new nomination for inclusion within the health benefit package is appraised based on standard principles of health technology assessment, and only interventions that are found to be cost effective are included within the health benefit package. And in order to do that, there is a system of coordination with India's HTA agency that has been established, and there is a formal process of accepting nominations into the health benefit package that has also been created. So a separate portal has been created on the NHA website, whereby there's a structured information that is obtained for any submission that people want to put up for inclusion into the health benefit package. And then there are a whole range of interventions that are being done in order to organize care around conditions rather than simply looking at them in terms of individual services or facilities. So this first chapter actually summarizes some of the key questions that are invited for stakeholders to provide their views on and the feedback on with regards to the extent to which it is felt that the approach comprehensively captures the value within the value-based care, and a comment on the overall appropriateness of the framework, etc. So that's the broad set of questions that are posed at the end of this particular section. The next section of this consultation paper talks about the introduction of a pilot for testing value-based incentives. And in order to do that, basically, if you look at the current model of incentive disbursement under the PMJY, you can see that largely the incentives are structured around different accreditation systems. And these accreditation systems inevitably ultimately look at basically the inputs and the infrastructure. So whether you talk of NABH certification at the entry level or full accreditation, or you talk about the bronze certification, each of these are basically certifications that measure the infrastructure, inputs, etc., and to some extent the processes. But once the certification is done, there's not a very systematic effort at looking at the outcomes, patient outcomes, level of satisfaction, etc., all those parameters. So those are mostly the incentive criteria. And then there are others, like, for example, if there's a hospital that has a teaching function also, then in order to ensure that there are more hospitals that are incentivized to create health workforce, so this incentive is available. And then for, as I mentioned, for aspirational district, there is a 10% additional incentive. Now, the problem with these incentives is, again, as I mentioned, it's more around inputs, infrastructure, etc. And there is lesser of an emphasis on outcomes and quality of care. So as a result, what we are proposing in the future is that we try and create a system of incentivization where, while 50% of the total incentive amount continues to be estimated based on some method of certification, but the remaining 50% is estimated based on some metrics that is developed that ultimately measures the outcomes of those treatments that are delivered. So the key question then becomes that how do you measure the outcome of a particular treatment, and how do you justify that whether a particular treatment that has been done is of high quality or poor quality, or what are the outcome indicators that you measure. So in order to do that, we basically shortlisted 3 criteria based on which we decided that the outcome criteria would be determined. And these criteria, the choice of selection of these indicators were based on these three criteria. First, we wanted that these indicators should broadly represent the overall aspirations of UHC. They should represent the overall framework of health systems performance measurement. The second is that we want that the entire data that we collect for indicators is something that doesn't impose too much additional work on those who have to collect this data, and it is something that is generated through the routine systems of data collection. And the third important criteria that we wanted to keep is that whatever information is being collected, that remains internally valid. So which means A, there is no bias in reporting of that information, and two, that there is no kind of gaming within the system to fudge any kind of data that is provided. So with these three criteria, we ultimately narrowed down on three different domains of universal health coverage, which include responsive patient-centered care, financial risk protection, and better health outcomes. So these were the three broad domains that we look at when we look at universal health coverage. And within these three domains, we identified indicators. For example, in responsive patient-centered care, we chose two indicators: beneficiary satisfaction and the absence of any kind of a confirmed grievance that is reported by the patient. For financial risk protection, we decided on measurement of out-of-pocket expenditure. And for looking at health outcomes, we chose on two indicators. One is readmission rate, and second is the extent to which there's an improvement in the functional quality of life of the patient following the treatment. So eventually, these are the 5 indicators that we have chosen in order to generate a kind of performance assessment for the hospital, which will ultimately lead to delivering some kind of incentives, financial incentives. So these are the 5 indicators. And in the subsequent slides, I'll explain to you how we propose to collect this information for generating each of these indicators, and how we intend to compute the process, the computation methodology for determining the extent of incentive that a person receives, a hospital receives. But before I move on to that, it is also important to highlight that there were other indicators also, which are equally important in order to comment or in order to gauge the extent of quality of care that is being delivered. However, these were ultimately not considered for inclusion to determine the incentive amount to be disbursed to hospitals. Now, these indicators include, for example, hospital-acquired infection rate, a very well-established indicator to measure the quality of care. However, the problem with this indicator for inclusion to compute the incentive amount is that if you include this indicator, then there's always a potential that there is going to be a significant underreporting of this indicator, because this is dependent on the provider self-reporting, and if that is not reported, then obviously this becomes a meaningless indicator. The second indicator that was again widely discussed and debated was mortality, because again, mortality is a very often used indicator for judging the outcomes, patient outcomes. However, the problem is that mortality has several confounders, and it is very difficult to really take out the confounding effect of different baseline patient level characteristics besides the care related characteristics of the hospital. So as a result, again, this was not considered favorably. Even disease-specific mortality could have been considered, but disease-specific mortality was also not chosen, because then this could have led to a tendency or a perverse incentive for the hospitals to cream skim only the less severe spectrum of the overall population. And that would have meant that the hospitals would have denied care to those who are more sicker, those who are more likely to die. And as a result, the ones who are more likely to need more intensive care, they would be shunned away from the hospital. So as a result, this was again not considered within the measurement framework. And the third indicator was the length of stay. The length of stay again is a good indicator, because you expect patients to be put on made ambulatory as early as possible for better outcomes. However, again, this was not considered, because that would have meant a pressure on the hospitals and the providers to discharge the patients early, even in cases where they require a prolonged stay because of some kind of complication, comorbidity, or some kind of coexisting some disease. So as a result, these three indicators, while they continue to be used in order to monitor quality of care, they're not going to be used in measurement of incentive structures. An overarching conditionality for being eligible to avail any incentive is that the hospital does not have any fraud against it which has been proven. If there is a proven fraud against any hospital, then that hospital automatically, irrespective of any outcome, any certification, is not going to be considered for any incentive. Now, moving to each of the different indicators, beneficiary satisfaction rate, it's a system that is already established. There is a dedicated call center which does calling of patients who are discharged from the hospitals. And on the second day of discharge, there's a call that goes to each patient asking them about their experience. So this is a question that would be posed again with a slightly different language, with a kind of a visual analog scale, where patients would be asked to report on a scale of 0 to 1 in terms of how satisfied they are with the hospital encounter. And in order to ultimately give certain marks to the given hospital, there is a grading that has also been developed based on the satisfaction scores. And this grading has been developed based on the current experience of how hospitals, what are the kind of scores that generally we find in different patient satisfaction surveys. Because mostly we see that patients generally tend to report more optimistic scores to providers in terms of their satisfaction. So as a result, we've kept the cutoffs and the class intervals that are relatively on the higher side. The second indicator is readmission rate. Now, readmission rate is classified as a case of readmission that takes place within 30 days of discharge from a given disease for a hospitalization that is for the same disease condition. So that's the definition of readmission that we are considering. And again, it's something that is auto-calculated from the transaction management system, whether the readmission takes place in the same hospital or in some other hospital also, given the fact that there is a patient ID based on which the patient is tracked. So as a result, there is a possibility to compute this indicator. And again, the readmission rate scoring criteria is again based on standard international literature of what is an acceptable or not acceptable readmission rate. Now, we do recognize that there are certain packages like dialysis, chemotherapy, and other daycare packages, which where there's the question of readmission is relatively not appropriate. So as a result, for these type of packages, we will compute their overall scores with the available remaining indicators. So readmission rate would not be computed for these packages. The third indicator that we have chosen is out-of-pocket expenditure. And this is again the same call center interview that goes on the second day of discharge will also elicit information whether any expenditure was borne by the patient out of pocket for either medicine or diagnostic or any informal charge or any direct medical expenditure that may have been incurred during the hospitalization in the empaneled facility. This excludes any expenditure that may have been incurred on travel, on boarding, lodging, etc., because this is something that is not covered as part of the scheme. The scoring criteria here are a binary scoring criteria. So if there is any out-of-pocket expenditure, then there is no mark for this particular indicator, whereas full marks if there is no out-of-pocket expenditure. Now, there was again a discussion that while we have a scheme that classically claims that there is no out-of-pocket expenditure, and the hospitals also empanel with the consideration and with the kind of agreement that there is going to be nothing charged, and if there is something that is found that the patient has been charged, then there is a kind of action that is taken against the hospital, some kind of but so as a result, on one hand there was this issue that why even include such a criteria where there is a kind of either or kind of decision making, that if there is that there has to be a kind of action against the hospital if there is a proven case of expenditure by the patient. But we still chose to include this indicator for the simple reason that in cases where expenditures are proven to have been incurred, the hospital, after an inquiry, is made to pay back that amount of money to the patient. And for subsequent such complaints, there can be more actions against the hospital. So what it means is that if the hospital is to refund back the same amount of money, that means that the hospital is in a way penalized for charging a certain out-of-pocket expenditure, but only in that particular case only. Whereas if we include that as part of our measurement framework, then it eventually means that the remit of the influence extends beyond just that particular case, and the extent of disincentivization is going to be borne for all the services that are being delivered in that hospital. So that's why we retained this particular indicator, and also for the fact that it is an important indicator of financial risk protection. The fourth indicator is a confirmed grievance. Again, there is a standard process of obtaining grievances from patients, either with regards to, for example, denial of care or any kind of grievance that the patient reports for. And there is a centralized system of grievance redressal and management system. And again here, if there is a proven grievance, that means after the receipt of a grievance, there is an inquiry and that finds that the grievance was true, then there is a 0 mark that is given to the hospital, whereas full marks if there is a no confirmed grievance against the thing. So till now, all the 4 indicators that we have discussed are such that there are current mechanisms of data collection that have already been in place. And perhaps it requires a bit of a fine tuning on how we collect this data. For the 5th indicator, which is improvement in the health outcomes, which is as per the health related quality of life, this is an area where there is going to be an additional work in terms of data collection. And the additional work entails use of an instrument, which is EQ5D5L, which is a generic tool to measure the quality of life, where questions are posed in 5 different domains: mobility, self-care, usual activities, pain, discomfort, and anxiety. And the patient is interviewed to ask to report his status in each of these different 5 domains. And he reports a certain level at which he are. And for each of the domains, there are 5 different levels, starting from no problem at all to being unable to walk at all. And based on whatever is the response of the patient, there is a particular profile of the health state that is created. So in this case, if you look at in the first domain, the score is 1, second domain, the score is 2, third, it is 3, 4, and then 5. So what it means is that the health state is, the profile of the health state is 1, 2, 3, 4, 5. And there is a value set that has been created for Indian population for EQ5D, which specifies for each of the different health states that could potentially arise after you use this particular tool. And there can be 3,000 plus health states that can arise. For each of those health states, there is a valuation of the quality of life that is available. So this would be IT integrated. So the job would only be to ask the patient on these five questions, and based on that, a profile would be created. At the back end itself, with the integration of this value set, a score would be auto calculated. And this process would take place at 2 time points. One, at the time of admission, and second, at the time of discharge, 15th day after discharge. And the difference in the value of quality of life that is reported by the patient ultimately leads to the relative change in the improvement in quality of life. And this will eventually lead to a percentile based improvement in health related quality of life. So, and the reason why we wanted to keep it percentile based is because then there is a kind of a relative competition between hospitals to find out that where is it that there is a better outcome in terms of patient health status and quality of life. The other reason why we did not want to keep absolute benchmarks is because it is not fair to give some kind of set absolute benchmarks for improvement in quality of life, because there could be patients with different levels of disease condition, levels of comorbidity, complication, etc. So this is the final flow of how this EQ5D would be administered. 5L will be administered to assess the quality of life. One, at the time of at the admission, where the Arogya Mitra will be administering this questionnaire, which will lead to a profile generation of the health state. Health score would be auto-generated. Then a follow-up call takes place at 15th day following discharge. Again, the profile and the score would be generated, and there would be a relative improvement in the health status that would be determined. We also want to create a provision whereby patients who have a smartphone and are literate, they are able to report, self-report on each of these 5 indicators through an app that we are proposing to create. And with this, we aim to roll out a pilot, which will be rolled out in about 5 to 6 states. There would be trainings that would be imparted to relevant stakeholders, and then there would be some IT integrations as per the requirement, and data would be collected over the next few months, and then that data would be analyzed in order to set some benchmarks and to test the systems of this data collection session. And this would also be used to ultimately create a dashboard of hospital performance on the website that would enable everybody, all stakeholders, including the patients, to actually look at the quality of the hospital, the performance of the hospital in terms of each of these 5 different domains. And moving forward, we want as much as possible granularity in terms of performance assessment, not just at the hospital level, but maybe drilling it down to the specialty level, or even down from the specialty level to the teams of health professionals who are involved in delivering the care in each of these specialties. So finally, we end up this consultation paper with a set of questions that try and seek opinion of the stakeholders on the appropriateness of these 5 indicators, the methodology of the data collection for each of these 5 indicators, and how this data is proposed to be computed, and marking system, how it is to be done. And then we also seek opinion of stakeholders to suggest additional new indicators that they feel would be of utility for representing the value within the PMJY ecosystem. So we have also created a Google form that can be accessed through a link that has been posted on the NHA website. And we are inviting comments with a last date of 21st of July, following which we'll try and summarize all the feedback, and we'll try to draft responses to each of the comments that we receive, and also make changes in the entire approach towards our value-based incentives. So maybe I'll stop here, stop my screen share, and I'll be happy to answer any questions if there are.
Great. I've been tracking some of the questions, Dr. Prinja, that have come in. I'll start with a sort of higher level question, which is, you started this presentation contrasting volume-based care with value-based care. In India, a lot of the high-value health systems historically been through volume, so volume and value rather than volume versus value. I wanted to sort of maybe invite you as a starting point to think about how, in the size of country and the size of the need, how volume and value might work.
Yeah, I think so. So what I tried to suggest was that the traditional payment methods that either involve a fee for service or a case-based bundled payment, the way it is currently in our scheme, they basically try and calculate the overall amount of payment that a hospital receives based on the amount of services that are being delivered. So based on the number of packages that have been delivered by the particular hospital. So, but there isn't any specific measurement on the quality of care that is being delivered, or the outpatient outcomes, or the satisfaction. So moving forward, if there is some effort at tracking these outcomes through these indicators, then obviously there is an incentive amount that is calculated. And since it gets applied on each of the different services that are being delivered, so automatically it comprises of both the volume and the value in that sense.
Okay. We have a question here from Ankit, Dr. Prinja, regarding the HEDIS measures, which are measures used in the US that are specific to individual health conditions. So measuring the outcomes and performance around, for example, a cardiac pathway. And in your presentation, you're describing this sort of more generic outcomes measure. Could you please comment on this? Is this part of the evolution that NHA would like to go to adopt more health-specific measures? Sure. If so, how, and if not, why?
Sure. I think that the intent is to have a more generic valuation of the patient outcome, rather than a more disease specific, because the more you make it disease specific, the more is there a difficulty in making any kind of a cross specialty comparison. The other reason that we particularly feel more inclined towards use of the EQ5D or a generic tool is because there is the EQ5D has also been recommended for different utility estimations as part of the recommendations under the Health Technology Assessment Program in India. So since it's also going to be the basis of all kinds of cost utility analysis that are going to be done, so we also felt that there should be some kind of a congruence between what the HTA agency does and what the payer agency also evaluates the patient outcomes on.
Got it. I think maybe one follow-up there is how do you, in this pilot where you're going to be testing this model, you had mentioned it'll be piloted first. Could you help us understand what the expected outcomes or learnings are from this pilot?
So the expected outcomes or learnings would be that it would help us test the systems, the processes based on which this data collection takes place. It also helps us to assess the process of the validation of the methods that we are trying to use, any kind of course corrections that we need to institutionalize in order to collect this data, or in order to maybe look at the validity of the information that is getting generated. I think those are the prime intent. And also it helps us to sort of estimate a kind of a baseline, which is also important to understand, to maybe later on see if there is any kind of a shift, if this kind of data collection systems to generate incentive amounts, maybe it brings about a kind of a change in the behavior of the providers altogether, or maybe change in the reporting patterns, etc. altogether. So that's the intent.
Okay, great. So operational insights, and then also important role in baselining. A question from Pankaj around how prescription data might be used to understand quality. And you might actually interpret that question more broadly, which is, in addition to these 5 indicators, what other data sources, including prescription data, might be integrated to assess for quality across these value-based care related programs?
So if you would have looked at our set of indicators as well, you would have realized that none of our indicators on assessing the patient quality are such that really try and hold the kind of apparent flexibility at the hand of the clinician in terms of treating a given case. Even the standard treatment guidelines that we also have as part of our PMJY scheme are not very, I would say, statutory in their way that you have to necessarily treat with these drugs or these conditions, etc. And secondly, while we do recognize the fact that there's a significant importance within India on trying to ensure that there is an appropriate prescription behavior among the providers as well. This is something that is, there is so much of heterogeneity, and there is so much of, what should I say? Heterogeneity even within the clinical opinion of different cases. And then it may vary according to the level of severity, etc., and all those conditions. So as a result, I think that maybe in a few years down the line, once systems are stabilized with this first set of indicators, perhaps prescription audits may become an important part. And also once the IT systems become enabled to perhaps have some kind of AI systems that are able to read the prescription slips, but then only perhaps we will be able to move to an era where the prescription audits are also used as a measure to, as a means to test the quality of the care.
Okay. So requires further examination before implementing something like that. Thank you. So a couple questions that I will cluster together around patient engagement. One question is around, in addition to the call center, are there other mechanisms for patient engagement? And you could interpret that from the payer or from the provider in terms of post-discharge feedback, for example. Another question around just mechanically, how do we ensure completion rate of surveys that are administered through a call center?
Right. So I think that besides the call center being used as a mechanism to collect some of the patient reported information, I did also mention that we're trying to create an app that the patients could themselves use and self-report on some of these indicators and the information that could be used to generate some of these indicators. Currently, we have a coverage of the call center that has gone up to close to about 70%, around 60. It hovers between 65 to 70%, and that's where we do not necessarily aim to use that for any kind of incentivization. So I think that if this becomes important enough to compute incentives, then most likely the coverage of the call center interviews would also go up. And in a way, we also hope that the entire process of building in these kind of data systems for generating incentives would also be helpful to nudge some of the other systems that we have created, like grievance redressal portal or the call center. So I'm sure that these systems would also get a boost or a bit of a kick to make sure that the coverage is high and the quality is good.
Wonderful. There's a question from Akash, and I think this is a theme in coming in some of the other questions around the continuum of care. You mentioned that continuum of care is an aspiration or one of the initiatives to really link the two pillars of Ayushman Bharat. And it's sort of the question I think Akash is asking is like, how can we see incentives and transformation of how things are delivered? So it's not just in the tertiary setting, but also pushing things to the primary and preventive health.
Yeah, I think that's a very interesting question and something that is worth considering. Something that I hope that in years to come, it should become a reality. But so right now, what we're trying to do is that we're trying to institutionalize this kind of convergence between the primary, secondary, and tertiary care by having integrations at the level of IT, wherein there can be tracking of the beneficiaries and the patients and the individuals who go from one level to the other level. And there's both tracking up referral and back referral. We also want to have some kind of integration with in terms of the people. That means the individuals who are delivering care at the primary, secondary, and tertiary care. There should be some kind of cross-talking between these three levels, and then there should be some integration in the processes. So these are the three points at which we are aiming at the integration: process, people, and the IT. We do recognize that in good systems, the incentivization structure also tries to make sure that the primary care gets incentivized relative to the secondary and the tertiary care, and which also means that perhaps lesser hospitalizations get incentivized than more hospitalizations. So, but I think that's something that is definitely a work for the future, but definitely something that is worth considering as well.
Okay. Maybe actually this next question could give us a bit of a more vivid sense of how this operates in practice. Manjunath is asking, could you take an example of a package like knee replacement or dialysis? And some of the follow-up questions are the incentives big enough to motivate providers? Would they be satisfied with just basic reimbursement without really trying to improve? So maybe take an example and walk us through, and maybe even reflecting on this sort of question about prevention or driving to more primary care.
I think that's a very fundamental question on behavioral economics, that are the incentive amounts sufficient enough to drive the provider behavior, perhaps, for that matter. But I think that what we are creating is not just a financial incentive. A financial incentive is definitely one part of it, which does get calculated based on whatever data systems that we're putting in. But it also creates a kind of, as I mentioned, performance benchmarking and a portal that gives a ranking to the hospitals. So it is an attempt to not just create incentives for supply of services, but also create a mechanism of information that shapes the demand for healthcare services. So if you have this performance listing of hospitals, let's say, even drilled down by the specialty, then it also makes your consumer or the patient more informed, at least in future, that if there is a need for a particular type of care, then he can also look at which hospitals are at what level in terms of their quality of services, etc. And then he can make a more informed choice on that front. So which means that it has a supply side push as well, and then there is a demand side anticipated flow as well that is coming in. So I think that we'll have to wait and see that how the providers do respond to the kind of nudges that are being created.
Perhaps that's something in the pilots we can learn as well. Lalit is asking about something that you commented on around disease-specific mortality. The reason you chose that was because you did not choose that was because it was sensitive to gaming, that providers might just choose the healthier patients. Lalita asking a related question around readmission rates, which are also sensitive to different levels of severity, comorbidity, age. And so is there any way that risk adjustment might be incorporated in this approach?
Yeah, that's an excellent question, and something that we hadn't expressed very explicitly in the consultation paper. But this is something that has already come as a suggestion to us through different sources as well. So we've definitely taken note of that, and we do recognize that there is a need for some kind of risk adjustment across hospitals, given the differences in case mix. And one of the potential that sources of data that we have currently to make that kind of risk adjustment is the ICD classification. So we, in our new TM, we have very recently introduced the ICD-11 classification system of morbidity, which to an extent enables us to make sure and to highlight or identify the levels of the differences in level of severity or comorbidity or complication. So we also have a provision of having the providers to be able to enter not just one primary diagnosis, but 4 primary diagnoses and a multiple of other secondary diagnoses also. So I think that piece of information that we've recently incorporated in our TMS would enable us to make some kind of stratification across hospitals with different levels of case mix, and that could be potentially used to adjust for the extent of readmission rates, etc.
Okay, so perhaps.
Yeah, but just to add, readmission is relatively less amenable to gaming because readmission can take place at a hospital other than the one where the first hospitalization took place. And more so that if the hospital denies a patient admission because he doesn't want to show a readmission, then automatically that raises a grievance also. That can result in a grievance by the patient also in the grievance portal. So readmission relatively has sort of some corrective measures also that can possibly link to that.
Yeah, thank you. Really rich set of questions from folks. I think Deepika, you wanted to ask a question live. Please come in.
Thank you very much, and it's a delight to see Dr. Prinja, you at the center stage of PMJY and paradigm shift that I see in the working of PMJY. So my question is around the prescription audits. You know, now that you have adopted the standard treatment guidelines, which I was involved in making, there is a lot that is that can be unlocked in them because they were being made, the referral linkages were, you know, at the back of the mind, and so they were designed in that manner. So I think there is a scope of that, and also at least if we could keep in terms of prescription audit, what is a workup that the doctor has done, so that shows the level of sincerity that the doctor has taken towards the patient. So if we just shy away from policing on the drugs and investigations, we could at least look at the workup, which should not ruffle any feathers. So that is one point that probably at this stage we can look at.
Thanks, Deepika.
Sure. I think, Dr. Deepika, you've raised a very important point, and this is something that we are also in the process of working on. So what we're trying to do is that the reason why we've sort of kept the prescription audit currently out of the ambit of performance measurement for incentive calculation is because right now the way that we are getting the information on the prescriptions is by providers uploading their case sheets or prescription slips. And what it means is that we need more competent AI softwares to read those kind of prescription slips, etc. The more we add in terms of information that has to be fed into the system by typing in, that increases the volume of work at the hospital level, and that's why that creates a bit of a discomfort. But the second point that you mentioned about trying to look at that the appropriateness of the processes, the diagnostics, and the care that is delivered, I think that is something that we are working on as a parallel stream, where what we're trying to do is that we're creating IT fields which are condition specific and package specific, that would enable us to comment upon that whether the care that was being delivered was appropriate or not. So for example, just to give you an illustration, it's like if there's a case of breast cancer, and then you have, let's say, the staging of the clinical staging of the breast cancer can be documented, then we know that linked with the clinical staging, there is an appropriateness of a certain diagnostics that should be done for the subsequent workup. So for example, in the early stage, perhaps you would only do with a chest X-ray or an ultrasound or some LFT and KFT, but you may not like to go in for a CCT for that matter. So that's the kind of thing that I'm trying to refer to. Or for example, in therapeutic area, you have one data field that is asked, and that is about the immunohistochemistry and whether the HER2 new status was positive or negative. And depending on that, you can make a judgment whether the drug trastuzumab that was given, whether that was appropriate or not. So that's where we are right now. So we are incorporating IT fields that are specific to each package and disease areas. And we have started this in 3 areas: cardiology, oncology, stroke, and dialysis. Those are the areas that we have shortlisted. And again, they have been shortlisted given the volumes that these cases have. I know Chintan has time as well.
Thank you so much
Yeah.
for the rich set of questions. We will, thanks to the SWAS team, to capture some of these questions to share back with Dr. Prinja. Encourage you all to respond to this consultation paper through the Google form that's been provided. And I think we have to wrap up here. Go ahead, Shivangi.
Thank you so much, Dr. Prinja, for a very insightful presentation and also engaging with the questions in as much detail as possible. A big thank you for that, and a very big thank you to Dr. Maru as well for moderating and managing a very engaging Q&A session and making it that much more valuable. I know we do still have a lot of questions that are pending. You can email your questions to allhands@swastap.org. We will write that email down and send it to all our groups. And as mentioned before, you can, the feedback is invited on the consultation paper till Thursday, 21st of July. The link has just been posted on the chat box. Please direct your feedback and comments there. With that, we come to the end of our July All Hands call. Once again, thank you to our speakers. Thank you to our attendees for attending. And we will see you next month. With that, wrapping up. Good evening.
Thank you very much.
Thank you.
Thank you.